Mr. Chairman, dear colleagues, it's a great opportunity today to speak about a very important aspect that has got many advances in the recent years. These advances came from a change of the concept of renal osteodystrophy, from being a disease of bone abnormality affecting the person in the form of fractures, to a disease of cardiovascular affection and increasing the mortality. And this new paradigm is encroaching on our speak in its first part. Vascular calcification has been prominent in our patient, and we know that 50% of our dialysis patients die from cardiovascular disease. In a big retrospective analysis of more than 35,000 patients, the risk associated with disordered mineral metabolism was exactly like the development of severe anemia in our patients, although we give much of our concern on correcting anemia and little of concern in correcting the mortality due to hyperparathyroidism, although the figure is the same, increased risk of mortality by 50%. Another point, when we have young people on dialysis, 20 to 30 years, in this study, the calcification score out of 16 studied patients by computerized tomography, 14 of them had coronary artery calcification, and of course this is reflected by early mortality. So it's a real important aspect, and this calcification score increases by the duration of dialysis, by the age, by the presence of diabetes, by high phosphorus, by the duration on dialysis, the lipids, the inflammation, the hypercalcemia, and the positive calcium balance. And this calcification is a little bit different from what happens in the non-renal, non-uremic population, because it affects both the intima and the media. And it is not rare. It is present in 2/3 of incident dialysis patients. So it's a drastic, if we are speaking about around 50,000 Egyptian patients on dialysis, we are addressing this possible vascular calcification in more than 30,000 of our patients. So it is something very serious that needs to be addressed. And the mechanism of this could be understood by when we know that this mesenchymal stem cell could go in different pathways, can go to form a adipocyte, or to do osteoblast and chondrocyte, or to do a vascular smooth muscle cell. And to go in this pathway, it needs the presence of some transcription factor called RUNX2 and MSX2. So if we imagine that the uremic milieu and also the aging and the diabetes favor this transformation of this vascular smooth muscle cell into osteochondrocyte because of the presence of this transcription factor RUNX2 and MSX2. So this smooth muscle will be converted into bone or cartilage. These promoters, there are promoters and inhibitors of this process. When we have decrease in the GFR, there are some disease-related factors like the hyperpara that we are speaking about in detail today, the inflammation, the hypertension, the advanced glycation and the product and the oxidized lipids. And there are some treatment-related factors. All our doctors overprescribe calcium-based phosphate binders and vitamin D. They don't tailor the calcium dialysate according to the patient. And all these factors will lead to affection of this protective adaptive mechanism, because in the uremic media, the inhibitors of calcification or the protectors of calcifications are decreased. What are these protectors of calcification? You can see them in the previous slide here, like an army protecting the vessels, the fetwin, the osteoprotegerine, and the pyrophosphate and the matrix galaprotein. All these inhibitors are decreased in uremia, and on the other hand, the transcription factors are upregulated, and the end result will be the following: apoptotic cell death, vesicle formation, and ending into this vascular calcification, which is catastrophic as a prognosis for our patients. So we should go and try to revert these mechanisms as early as going to hyperpara. We know that the main mechanism of stimulation of the parathyroid gland is the deficiency of calcium through the calcium receptor. But there are two other very important mechanisms: the deficiency of vitamin D as the kidney decreases in function, and the increase in phosphorus. All these are mediated by different receptors: the vitamin D receptor, the calcium receptor, and some claim also that the phosphate receptor may act through TGF-alpha or EGF receptor. The end result will be increase in the parathormone secretion, synthesis, and cell proliferation. And this will end into, with progression, into a sort of vicious circle, because when we have this decrease in the receptors, there is much PTH generating very large and monoclonal growth pattern, ensure that the calcium receptor and the VDR are significantly underexpressed. Control of PTH secretion synthesis by calcium and vitamin D is marginalized. There is increased serum phosphorus, and the bone will give the calcium and the phosphorus. This phosphorus will stimulate again this parathyroid to increase its secretion, and we finish by having a nodular hyperplasia, which is a vicious circle. When we do just a simple investigation, which is the sheep ultrasound, this will not show the normal parathyroid gland, which are not detectable by ultrasound, but it will show the parathyroid when there is diffuse hyperplasia, early nodularity, or single big nodule. So this is a very simple test that everybody can do. In a big Spanish study in non-dialysis patient, over 1,836 patients, published in NDT 2007, the serum vitamin D continued to fall, and the serum PTH continued to increase as the CKD progressed. But we see that in the early stages of CKD, we have some hyperpara here, and we have decrease in the vitamin D. So this process is ongoing all the time from the early days of non-dialysis patient. And it has been clearly shown in the SEEK study, which is the study for the evaluation of early kidney disease performed on more than 1,800 patients, that hyperpara is present in 56% of those with values of GFR less than 60 milliliter per minute. I mean, those patients starting from stages 3, 4, 5, more than 56% of them have hyperpara. So we meet this hyperpara every day, and we should know that it has got an important association with mortality. And this, as another slide showing the same relation. Therefore, the international societies all over the last years tried to put guidelines to control this. And the first guidelines came from the KDOQI. And these KDOQI guidelines actually did not achieve the target. As you see in this DOPS study, which was carried in 7 countries, showed that the percentage of the patient within these KDOQI guidelines did not reach 30%. And the patient with, most of the patients felt away from the guidelines. So it seems that these guidelines were not so realistic, and that therefore the international societies tried to change the concept. Because management of PTH on patients on dialysis continue to be problematic, and there is concern that KDOQI guidelines, which suggested a range for intact PTH of 150 to 300 to achieve normal bone turnover, cannot provide reliable index of turnover, because the bone turnover, the mineralization, and the volume don't go hand in hand. Sometimes we may have a high turnover with different status of PTH and vice versa. Therefore, the new KDIGO guidelines are better addressing this concept by mentioning that in the chapter of treatment of CKD-MBD, that abnormal PTH level in patients with CKD stage 3 to 4, not on dialysis, the optimal PTH level is not known. However, we suggest that patients with levels of intact PTH above the upper normal limit of assay are first evaluated for hyperphosphatemia, hypocalcemia, vitamin D deficiency, and the evidence is 2C. It is reasonable to correct these abnormalities with any or all of the following: reducing dietary phosphate intake, administering phosphate binders, calcium supplement, and or native vitamin D. In patients with CKD 3 to 4 not on dialysis, in whom serum PTH is progressively rising and remains persistently above the upper limit of normal for the assay despite correction of modifiable factor, we suggest treatment with calcitriol or vitamin D analog. In patients with CKD stage 5D on dialysis, we suggest maintaining the PTH level in the range of 2 to 9 times the upper normal limit to avoid adynamic bone disease. We suggest that marked changes in PTH level in either direction within this range prompt an initiation or change in therapy to avoid progression to levels outside of this range. In patients with CKD stage 5D and elevated or rising PTH, we suggest calcitriol, vitamin D analogs, calcimimetics, or a combination of calcimimetics and calcitriol or vitamin D analogs be used to lower the PTH. Do B. It is reasonable that the initial drug selection for the treatment be based on serum calcium and phosphorus level and other aspects of CKD-MBD. It is reasonable that calcium or non-calcium based phosphate binder dosage be adjusted so that treatment to control PTH do not compromise level of phosphorus and calcium. We recommend that in patients with hypercalcemia, calcitriol or another vitamin D steroid be reduced or stopped. We suggest in patients with hyperphosphatemia, calcitriol or another vitamin D steroid be reduced or stopped. We suggest that in patients with hypocalcemia, calcimimetics be reduced or stopped depending on severity, concomitant medication, and clinical signs and symptoms. We suggest that if the intact PTH levels fall below 2 times the upper limit of normal, calcitriol, vitamin D analogs, or calcimimetics reduced or stopped. In patients stage 3 to 5D with severe hyperpara who fail to respond to medical pharmacological therapy, we suggest parathyroidectomy. These are the KDIGO guidelines. And now let's go a little bit more in depth, because now we have much weapons and we want to know which weapon to use in which condition. The treatment option are going to the mechanisms. What are the mechanisms, if you remember? There were the calcium, the vitamin D, the phosphorus, the parathyroid itself. So let's decrease the phosphorus, give vitamin D, stimulate the calcium receptor, remove the parathyroid if there is a problem, and some other coming, like the FGF223, the phosphatonin, affecting the angiogenesis, etc. Let's go first with the phosphorus and see that 1 milligram increase in the phosphorus increases the risk of vascular calcification by 2.5 years or more than 5 years of treatment with dialysis. So it is a catastrophe to have a phosphorus of 7, because if you have this, see how many years cutting in the age of the patient. And the problem comes with the control of hyperphosphatemia, that you will let your patient decrease his protein intake and enter in protein energy malnutrition, which is another risk for mortality. So how to adjust this by diet? It's a difficult target. But let's know some facts, that the plant proteins, humans don't have the degrading enzyme phytase, which has a bioavailability of phosphorus from plant-derived food relatively low, usually less than 50%. So we can let our patient, despite higher phosphorus content of some plant foods like beans, but actual rate of intestinal phosphate absorption may be lower per gram of plant protein compared to animal protein. Another point is eggs. Okay, we'll not give the patient the yellow part of the egg, but the egg white is very beneficial, up to the extent that there is a study that dietary egg whites used for phosphorus control in maintenance hemodialysis patient, a pilot study. So we don't want to let our patients suffer by telling them don't eat everything. We should select so they can eat the white egg. It is not injurious for them. Of course, we have the phosphate binders, which have got a very big spectrum, the calcium-based binders and the non-calcium-based binders, and we have many available in the market. Strangely, the comparable efficiency of different phosphate binders is not differing very much, but there is some differences regarding the change in the calcification, the coronary artery calcification. For example, in this study between sevelamer and the calcium phosphate binders, the treat-to-goal study showed marked superiority of the sevelamer, but the CARE2 study did not show the same superiority, telling that maybe the improvement was because of the lowering of cholesterol by the sevelamer. Some other studies, more recent studies, published in the JACE in 2011, shows that there is a percentage reduction of 19%. After adjustment, it is 11%, which is non-significant. And another study shows that 25%, and after adjustment, it is 12%. So it seems that the observational study saw some benefit of these non-calcium containing phosphate binders. Again, there is conflicting evidence on the effect on mortality. In the RAIND study, sevelamer was associated with a clear survival benefit when compared to the use of calcium containing phosphate binders. Here, the survival distribution, you see here that the sevelamer, which is in red, have better survival. But when they did another study, which is the DCORE study, you see that the red and the blue curves are very similar to each other, and this mortality benefit is not clear. But mind you that if you give calcium phosphate binders for patients with adynamic bone disease, you are risking something very serious, because those will not go to bone, they will go to vessels and increase the problem of calcification. So there is a real risk if you don't know by not doing bone biopsy that this patient, for example, has adynamic bone disease, and you're still continuing giving calcium phosphate, calcium binders, it is a problem. So high-dose calcium-containing binder increase the calcium load and risk of cardiovascular calcification, no effect on bone released phosphorus, and the compliance, of course, is problem. The vitamin D therapy starts by a GFR as low as 80, as high as 80, you start to have low level of vitamin D. And the vitamin D available in the market, we have different products, as you know. And the relation between PTH and serum calcium after administration of calcitriol is very clear, that vitamin D will help. And effects of therapeutic vitamin D on biochemical parameter, of course, are beneficial. But we should weigh the risks to the benefits. The benefits of vitamin D is PTH reduction and calcium homeostasis. But the risks are hyperphosphatemia, hypercalcemia, and vascular calcification. So when we are prescribing vitamin D, you should monitor the serum phosphorus very carefully to avoid the problems. Again, the story of survival has got some debates. You see here no benefit of survival in this Tentori 2008 study, and some 15% benefit in high dose by Kalantar-Zada, and 20% benefit by Teng et al. In 2005. Here, newer analogs of vitamin D, again there is conflicting evidence. Tentori did not show any benefit, while Teng et al. Show a benefit of 16% lowering in the mortality. In the recent years, 2010 and here in 2012, in the Kidney International, we are now having some new anti-proteinuric effect of vitamin D. By combining vitamin D analogs and AT1 receptor antagonist, we may block the development of kidney disease in a model of type 2 diabetes, and the renal vitamin D receptor expression and vitamin D renoprotection is clear here, and the level of the vitamin D receptors is very minimal in the juxtaglomerular cells and is very high in the distal tubules. So there is different concentration of vitamin D receptors. Now let's go to the calcium mimetic, which are indicated, of course, in secondary hyperpara, which is our talk today, but they are also indicated and they are very important in treatment of parathyroid carcinoma and in the treatment of primary hyperpara who are unable to undergo parathyroidectomy. Calcium mimetics act directly on the calcium receptor. They bind to the calcium receptor, increase the sensitivity of the receptor to extracellular calcium, and thus reduce the PTH secretion. So what they do is exactly affecting the receptor and reverting all the arrows which were up, they became down. I will repeat it again. All the arrows now are up, and when we block, all the arrows go down. Professor De Francesco, which is among us today, found another mechanism for this. The pathological rightward shift of the calcium PTH curve, which is seen in many patients with secondary hyperpara, could be reversed by sinacalcet treatment by shifting the curve post-sinacalcet, and this is very important. Sinacalcet reduces the calcium set point in dialysis patient. And this study provides nephrologists with new insight into the way sinacalcet works to affect the PTH level in end-stage renal disease. Sinacalcet attenuate the parathyroid hyperplasia in a rat model, and you see here how the parathyroid hyperplasia after sinacalcet, the staining here, proliferating cell nuclear, is decreased. These brown stains are less when we give sinacalcet in the B. It reduces the parathyroid hyperplasia in hemodialysis patient, and it affects biochemical parameter to control both. The goal is to control both the parathyroid and also the calcium and phosphorus. And you see here that when we compare the key feature of treatment effect on PTH, calcium, and phosphorus, the calcium mimetics will decrease all the parameters. The vitamin D will decrease the PTH on the expense of having some high calcium, some high phosphorus. The calcium-free phosphate binders, okay, there is no problem for the calcium, but they may affect other, they are not neutral, they are not very strong in this point, and the calcium-based phosphate binders will have the real risk of hypercalcemia and vascular calcification, as I mentioned. So what are the side effects of the calcium mimetics? Sinacalcet treatment should not be started if you have low calcium level. Perform repeated blood tests to monitor the calcium, phosphorus, and intact parathyroid hormone. Very low and very high level of PTH should be avoided. In clinical trial, the most common side effects were some nausea and vomiting. There are so many important trials carried on calcium mimetics, evidence profile. I actually will speak about rapidly about 5 of these trials, and Professor De Francesco will speak about the outstanding EVOLVE study, which was actually one of the late-breaking trials that has been announced in the last American Society of Nephrology a few months ago by releasing the results of it. When we go to the first phase 3 studies, the phase 3 studies were performed on a big number of patients, more than 1,000 subjects in the United States, Canada, Australia, Europe, and in all these patients in the phase 3 study, we find that sinacalcet enabled the PTH, the calcium, the phosphorus, the calcium phosphate product to achieve the K-DOKI levels. Another study, which is the OPTIMA, enrolled patients with mild to moderate hyperpara with a PTH from 300 to 800 at the baseline. And the patients were randomized to receive either sinacalcet or another line of treatment. And we find that the sinacalcet arm here, which was around 368 patients compared to the standard care arm, which is 184, the level of PTH after maybe exactly few months, it decreased to the range between 200 and 300, while it remained high in the standard care patients. And the K-DOKI targets occurred after a few weeks here regarding all the targets, PTH, calcium phosphate product, calcium and phosphorus, while it did not reach that in the control group. The third study, which is the ECO study, and ECO sounds for evaluation of the clinical use of Mansoura in hemodialysis and peritoneal dialysis patient. It was an observation study presented in the ERA Edita in 2008. It was a big pan-European study to focus on Sinacalcet in daily clinical practice. The goals were to evaluate efficacy, to understand the ways in which European nephrologists are integrating Sinacalcet in their practice, in the treatment, and to explore if there are identifiable treatment practices that lead to greater achievement of the KDOKI treatment target. By that time, there was no KDIGO yet. And the study design was very clear, and the median serum PTH level decreased by 50% after initiation of the Sinacalcet, and the calcium decreased by 6% to within the range during Sinacalcet treatment period. Because many people, when they prescribe Sinacalcet, are afraid of hypocalcemia. It is clear from this study that this side effect was present only in 6% of the patients, so it is not a very big number. And in a population like what we do, we prescribe much calcium to our patient, I think we will not have any of these. On the opposite, the hypocalcemia will be corrected. Most patients received a Sinacalcet dose of less than 60 milligram at month 12, and when you prescribe early, you can give less doses. And 70% of all patients were still on Sinacalcet after 11 months, which reflects in these 1,865 patients a good degree of tolerability. And in summary, this study got greatest achievement occurred in patients with less severe disease, and therefore we are speaking today about early management of hyperpara. Don't go when the levels are more than 1,000, because it will be more difficult to reach the target at that level. Then the advanced study, which was a global study over 330 patients, which was treatment plus low-dose vitamin D, will attenuate progression of coronary artery calcification over 1 year in hemodialysis patients, compared with those with only vitamin D in the absence of Sinacalcet. And the study population were adults more than 18 years with high calcium, high PTH, and if PTH is less than 300, calcium phosphate should be screening of the CAC score was followed. And we see that the primary endpoint was this CAC score, I mean the coronary artery calcification, with some other secondary endpoint. Ultimately, what happened is significant reduction in the risk of cardiovascular hospitalization compared with the control group by around 40% reduction. The part with Sinacalcet, less than 40% in the risk of hospitalization. And in the risk of mortality, it is decreased by around 20%, 19% reduction, which was non-significant. But here, the hospitalization is much less in the post-hoc analysis. Could we prescribe these drugs after renal transplantation? In these patients who may have hypercalcemia, treatment can bring calcium into normal range and provides correction of urinary phosphate wasting and normalizes serum phosphorus, as mentioned in this study giving Sinacalcet after kidney transplantation for those patients who have persistent hyperparathyroidism, of course. I will not mention the EVOLVE because it will be dealt with later. Parathyroidectomy rates, according to the time on dialysis, has been rather stable all over the years, but in this paper, who studied the effect of parathyroidectomy in 77 dialysis patients followed for 5 years, PTH decreased lower than the desired range, and calcium and phosphorus increased progressively within 1 year. They concluded that parathyroid surgery does not represent an optimal therapeutic tool for targeting recommended values. It is only left bone mass with enhanced osteoid formation can be increased by parathyroidectomy, so usually only reserved for very high level of PTH that cannot be controlled with combination of other types of therapy. Now, the element of phosphatonin. You know that phosphatonin, including FGF23, which is a fibroblast growth factors, and other factors, are gained much attention as a very potent regulator of phosphate homeostasis over the past few years. And we know that this FGF23 is coming from the osteocyte and in the distal tubule through some FGF R1 receptors and the closo, they lead to phosphaturia. This could be an important mechanism that may be a bystander, or it may be a pathogenetic mechanism. And therefore, we don't up till now know, although these levels are high in dialysis patients, and it has been shown that FGF decreases the PTH secretion, why they don't inhibit PTH secretion. I mean, theoretically, giving this phosphatonin should inhibit the PTH, the hyperpar. But they didn't find a strong relation to this, maybe because expression of the receptors is minimal in the hyperplastic parathyroid gland, and the anti-FGF23 antibody in a Japanese study in 2009 did not know much lower endogenous high FGF associated with high mortality. The role of FGF in the development of secondary hyperpara is an active area of investigation. High level of phosphate stimulate the secretion of FGF23 by bone cells, and FGF is known to suppress the kidney activation of vitamin D. As kidney function declines, level of FGF increase. So this is an active part of the research. We know that there is this FGF23 signaling bypasses the vitamin D in its phosphate effect, and you will find in the literature many papers about this. Last slide. RNA interference, transfected interfering RNA against human PTH into parathyroid cell cultured from patient could be a treatment in the future, and targeting angiogenesis have increased the expression of basic FGF and the VEGF that may be potential target for therapy. Thank you very much.
Thank you very much, Professor Hani. Now we would like to introduce Professor Angel Francisco. He was previously introduced by Professor Tarek Elbaz. He'll give us a resume about the EVOLVE study and the future of management of secondary hyperparathyroidism.
Thank you very much, Mr. Chairman. Thank you very much to Amgen for inviting me to be here. I'll tell you one thing. I have been dealing with hemodialysis patients for more than 30 years. And in the last 15 years, I haven't seen one single advance. So once we control the quality of water, ultrafiltration, and EPO, IV iron, that's it. We didn't have any single advance. And the reason is related to scale economy. It is really very difficult to invest $1,000 million to have one pill into the market for these patients. Very difficult, because only with 10 years of possibility to be in the market before the generic arrives. So really, we are dealing with patients that takes about 19 pills per day with a mortality which is 21% per year in USA, 14 more or less in Spain. And it's absolutely very difficult to show any kind of effect or any single drug. And what I try to do today is just to clarify how the administrators, they receiving new drugs arriving into the market. If you are a Minister of Health of one country, and I am a member of some laboratory, and I want to introduce in the country a new drug, you should probably ask to me, okay, guy, what is the price of this drug, first of all? No, because we are investing a lot amount of money. Yes, okay. What are the biochemical effects? What are the biological effects? What are the effects on quality of life? What are the effects of, many hard endpoints? And then this really very difficult answer. And what I wanted to do today is just to try to clarify what are the effects of this new drug that appeared into the market in the last 15 years, which is called calcimimetic. Before that time, I was prescribing surgical paratheodectomy in many of my patients. And I had quite a few troubles, because sometimes I perform 7, 8, and rest one middle gland here in the neck. Then next I move to the forearm implant. Then I have many troubles. I perform total paratheodectomy. And then calcimimetic arrives into the market. I was inducing hypercalcemia to my patient with vitamin D. So let me to summarize this clear definition. At that time I was talking about renal osteodystrophy, which today is nothing to do with the bone, particularly only with the bone, but also with calcification and survival. And KDIGO, they try to define the classification in order to different types: laboratory abnormalities, bone disease, and calcification of vascular and other soft tissue. Unfortunately, this classification of KDIGO is not very popular. So that you don't have many doctors saying, I have a patient with LB, which is laboratory abnormalities, high PTH, and bone disease. You don't find very often that, okay? But anyway, we are interested in to know what is the new drug, which is for us already, 10 or 15 years ago. But what this drug is doing, and when you try to control secondary hyperparathyroidism, you have two possibilities, either with vitamin D or either with calcimimetic. You have two phenotypes. Vitamin D only with the calcium is controlled, low calcium or low level or normal calcium. And calcimimetic when you have high calcium or high level or normal calcium. But I wanted to talk today with the phenotype calcimimetic. And I want to summarize what are the findings that we have in the clinic and the different studies looking at these effects that has been summarized by KDIGO guidelines. So what are the effects of laboratory abnormalities? Has been already shown here. A reduction in PTH in all the studies. A reduction in calcium phosphate, slight reduction in phosphate, and a reduction in calcium. So we know that. So the lab abnormalities, they work. So this is a drug that works for lab abnormalities. Let's see one example. You have this patient, high PTH, high normal calcium, and high phosphate. If you want to control secondary hyperparathyroidism, you prescribe calcium binders, you will have hypercalcemia. If you prescribe cevilamerol and tano, you won't have any effect on PTH. If you prescribe vitamin D, you will have hypercalcemia and hyperphosphatemia. If you prescribe calcimimetics, looking at the effect that has been shown in phase 3 study and clinical and daily practice study, you will have a reduction in PTH, a reduction in calcium, and a slight reduction in phosphate. So we know that. So we know that laboratory abnormalities are controlled, almost controlled, by calcimimetic. What about calcification? So let me start with one single example that was performed by Mariano Rodriguez in Cordoba, in Spain. He developed in rats that they were underwent 5-6 nephrectomy. In this chronic kidney disease rats, he tried to feed these rats with high phosphate diet. And all the rats, they developed vascular calcification. Chronic kidney disease, high phosphate diet, vascular calcification. And he looked at the effect of reducing diet, phosphate in the diet, or adding calcitriol, or adding calcimimetic. And the effects were really very clear. And what he saw was that just with a vehicle, just reducing the phosphate in the diet, there was a very important reduction in vascular calcification. There was no reduction with calcitriol, and there was an important reduction of the calcium when the calcium mimetic was added to the rats. So he shows, Mariano Rodriguez, he shows that low phosphate diet with calcium mimetic was able to control secondary hyperparathyroidism and vascular calcification. But these are rats, and we are human beings. So we need to go further and to show whether this effect it is also in different. But one interesting observation of Mariano Rodriguez, as you can see here in this slide, is that around the calcification foci, there was an infiltration of phagocytic cell, and this phagocytic cell, they have expression of calcium sensitive receptor. So it could have been that the effect of calcium mimetic could be directly activating these phagocytic cells. Anyway, what are the study trying to show? That vascular calcification with calcium mimetic is reduced, as we have observed in rats. That was the advanced study. What was happening with advanced study has already explained here, is that the primary analysis, which is the coronary artery calcification in patient receiving cinacalcet, was negative. However, the point is they have two possibilities to analyze the coronary artery calcification. One way is the Agatston score. So looking at the area of the calcified plaque and the density. And other one, it is in a three-dimensional, looking at the volume of the calcification. And they choose, the researchers, they choose Agatston score. And Agatston score, the primary aim was negative, almost positive, but in fact was negative. However, if they would have choose the volume score, the result, it would have been positive. Looking at the other effects, which are the secondary effect of the study, looking at the calcification of the aorta thoracic, aortic valve, and mitral valve, there was a really important effect in reduction of decalcification. So although advanced study looking at the Agatston score was negative as primary endpoint, the data based on volume score was positive, and the data in the secondary effect was clearly positive. So maybe it points, the results suggest that cinacalcet may delay vascular and valvular calcification in this population. In any case, there was a lesser progression. So, and then we go to the renal osteodystrophy, and the Minister of Health and the administrators, they could ask the question, okay, yeah, this drug is reducing PTH, but has any effect in the bone? You should show me that. Okay, this is the bona fide study. When I was young nephrologist, I was looking at the bone every day, because at that time we had quite a few problems related to aluminum-induced osteomalacia. Our patient on dialysis, they have spontaneous fractures and osteomalacia. So I was very involved looking at the effect and looking at the bone biopsies and so on. So I am very familiar with the bone biopsies. And you can see here that in severe hyperparathyroidism, you have a very severe peritrabecular fibrosis, an increase in this multinuclear osteoclast, increase in resorption lacunes, and also it's a high activity osteoblast, because this is a high turnover disease, not only osteoclast, but osteoblast all the time, right? So if we want to look at what are the effects on the bone turnover, we should look at the differences in what is called in the bone formation rate. If a patient is receiving tetracycline, these autofluorescent antibodies binds the mineralization front. If you stop the tetracycline, after several weeks, you give again tetracycline, then the autofluorescent antibiotic binds the area of mineralization. So you can see these two different bands, as you can hear here, and look at what is the bone formation rate. If we have a high turnover, the bone formation rate is very high. If we have osteomalacia, there is only one single line, right? So this study, the bona fide study, the primary objective was just to describe parameters of bone turnover in patients receiving sinacalcet, calcium-mimeric mean para, and after 1 year, during 1 year, and then looking at the bone biopsy at the beginning and after 1 year. I want to go very, very quickly with this study just to show you the results. And the results were, as you can see here, there was a reduction, a very clear reduction in the primary efficacy endpoint. It's a change in mean bone formation rate. So there was a decrease in the high turnover. And also, we observe as well it change in the PTH, of course, in the different biochemical parameters, and also change in bone turnover markers, either resorptive markers of the fibrosis. And you will look at the fibrosis here, you can see the differences at the beginning of the study and at the end of the study, so that there was a normal histology at the end, 0 baseline and 26% at the end of the study. And also, there was a severe hyperparathyroid bone disease. There was 17% at the beginning and only 4 at the end of the study. So we show that with calcium-mimetic, with mean para, we have a direct effect of the high bone turnover induced by hyperparathyroidism. Okay, so we have lab abnormalities, we have effect on calcification, we have effect on bone biopsy. What about clinical consequences? So the administrator, they ask, okay, yes, changes in lab biochemical effect, that's interesting. Probably changes in calcification, interesting as well. You have shown also bone disease, but I want more. I want survival. I want more hard points. And we should say to the administrators, oh my God, this is very difficult to show in dialysis population with such a high comorbidity. There's no one has able to see any effect on dialysis when you perform studies. Just the sharp study at the very end, controlling lipids at the very, very end. Okay, we'll try to do that. That's what Amgen says. Okay, we're going to do that. And at that time, I was thinking about, you risk very much. It's so difficult to induce any kind of effect in dialysis patient during many years. Okay, so this was based in observational study looking at the effect on the hospitalization and mortality that was written by John Cunningham. In observational study was a reduction in mortality and cardiovascular hospitalization. But EVOLVE was started. And it was based in the fact that reducing PTH, since PTH has effect on survival, if you reduce PTH, you would improve survival. But this is very naive in dialysis patient, very naive. Okay, sanacalcet control PTH, calcium and phosphate control outcomes. Why not sanacalcet could control outcomes? And this is one study. The major study has been done I'm quite sure that you will never assist during your long career in the future one study like that. No more. No more studies in dialysis patients such as the EVOLVE study. So the VOLVE was planned for 4 years. It's event-driven study, and it lasts for more than 5 years. And the reason is that the doctors that were in charge of the placebo group, they prescribed sanacalcet to their patients because they couldn't resist high PTH, 800, 900, 1,000. They say, okay, this is the placebo. So I took this patient out, and I will prescribe Minpara. That's one of the reasons of these difficulties. So you know that it was just the patient receiving placebo plus standard or sanacalcet plus standard. And one thing which is very interesting in this study is how statistical study was performed. You know, ITT study means one patient receive the drug 1 day and then stop, and he is in the arm that the group of patients that were treated with the drug. Okay? One patient was in the placebo arm, and after 2 months, this patient is moved because it's going up, because the doctor decided to prescribe sanacalcet, and this patient, it is in the placebo arm, in spite that they have receiving sanacalcet. So it's really very difficult to understand. So the primary analysis is unadjusted analysis according to intention to treat. The secondary analysis is multivariate, and then the lack sensory analysis means that if you stop the drug, you should look 6 months later at least to know the effect of the drug once the drug has been stopped. So this is the lack sensory analysis. Okay. So the final conclusion of the EVOLVE study is that the EVOLVE study is negative. So they couldn't show differences comparing in the intention and adjusted intention to treat analysis, that was the primary end study. They showed any effect in survival or, you know, in cardiovascular endpoints. So first of all, we should look at the, it's not here, yes, the age. There was a differences in baseline in age, 61 for sanacalcet, 60 for placebo. Okay, so that are the changes in biochemical. And when you look at these results, if we look at these unadjusted analysis with the difference in age, there was a reduction of 7% of the cardiovascular